Chaitanya, finally a postgraduate. Today I'm going to present an clinical problem solving in an atypical presentation of acute pancreatitis. Introduction. I think we would come across many cases of pain abdomen in the casualty. So acute pancreatitis is the most important cause of acute upper abdominal pain because its clinical features are similar to a number of other acute illness. It is difficult to make a diagnosis only on basis of symptoms and signs. The diagnosis of acute pancreatitis is based on two of the three criteria: abdominal pain, which is consistent with pancreatitis, serum lipase and amylase levels more than 3 times the upper limit of the normal, and characteristic findings from the abdominal imaging, I mean radiological findings. The sensitivity and specificity of lipase in diagnosing acute pancreatitis are undisputed. However, normal lipase levels should not exclude a pancreatic diagnosis. In patients with atypical pancreatitis presentation, imaging is also needed. So we experienced the cases of acute pancreatitis associated with normal serum enzyme levels. Both patients were diagnosed based on clinical and radiological evidence. These are one of the cases I'm going to show now. These are the clinical images. A 40-year-old man who presented to our casualty with acute sharp abdominal pain, epigastric pain, which is radiating to back, associated with nausea and vomitings. Patient denied any history of pancreatitis, I mean previous pain abdomen, and consuming alcohol or illegal drug abuse. No new medication had recently been started, and there was no history of abdominal trauma. He had cholecystectomy in 2004. On physical examination, he was febrile, heart rate 105, and blood pressure 130/80. He was in severe distress due to pain with severe epigastric tenderness. The remainder of his physical examination was normal, and laboratory test showed WBC count of 22,000 with neutrophilic predominance, hemoglobin 11.2, and platelets 3.8 lakhs. His comprehensive metabolic panel was unremarkable except for the potassium level 3.5, and amylase was 31, and lipase was 14. Since the patient was in severe pain and no clear diagnosis, we went for ultrasound imaging and also CT contrast. The CT showed fat stranding in the pancreatic head consistent with the pancreatitis and reactive thickening in the duodenum. Patient was admitted and kept NBM. We started him on IV fluids, analgesics, electrolyte corrections, and also antiemetics. We also checked his triglyceride levels, which were around 53. Symptoms continued to improve in the course of his hospitalization, and we discharged the patient after the resolving of his symptoms. These are the timeline of events. We couldn't see any fever spikes on the day one on presentation. Borderline, we could see that, and the further event shows his TLC count was decreasing, and the trends of his vitals, and also the trend of his symptoms where his pain abdomen subsided subsequently. Problem representation: sharp epigastric pain which gradually increased, and normal enzyme levels which were around lipase and amylase which were normal, and hypercalcemia which was around 11.2. This is the CT imaging, which showed peripancreatic stranding in the pancreatic head consistent with the pancreatitis pain, and also reactive thickening in the duodenum. Coming to etiology of acute